Welcome to the Seniors Flourish podcast, where it's all about helping occupational therapy practitioners working with older adults be the best they can be. And now your host, Mandy Chamberlain.
Hi everyone, before we get started, I wanted to talk about Seniors Flourish's sponsor, Great Seminars and Books. What I really like is that their mission is focusing on geriatric rehabilitation education and training for clinicians, which, as you know, is near and dear to my heart. They have great live courses focusing on topics such as clinical orthopedics, cancer rehab, or even topics such as clinical neurology. There is a course for anyone looking for evidence-based practice and treatment ideas while working with the older adult population. These are definitely some topics that I am interested in, and I think you should check them out too. So head on over to seniorrehabproject.com/great and use my promo code SRP25 to get $25 off your next course. Welcome, everyone, to the Seniors Flourish podcast. I'm Mandy Chamberlain, occupational therapist and your host of this show. Today, we are talking about occupational therapy, Pilates, and breast cancer with my guest, Naomi Aaronson. She's an occupational therapist and a hand therapist and a whole slew of other things that we'll kind of get into. But so I'm really excited about this topic, and I'm just going to welcome Naomi. Thank you for joining me today.
Thanks, Mandy. I really welcome the opportunity.
So let's just talk a little bit. I always like to kind of get started about hearing about people's OT journey. How did you get into OT, and how did you get into what your role is today?
That's a long story, but I'll try and make it as short as I can.
Okay. Condensed-ish version. Yeah.
Basically, I was a recreation therapist, and I was a recreation therapist for about 12 years, and I had done everything you could possibly do. And I had even taught at college recreational therapy, and I was looking for something that was more medically based. And I looked into OT, and I was like, wow, this is something, I like the idea that it's holistic, mind and body. I looked into speech, and I didn't think that would be for me. But I'm very action oriented, movement oriented. So I went to school for OT. I practiced in geriatrics and nursing homes for about 2 years. Then I got a job at a city hospital, and I was exposed to all these different diagnoses and to hand clinic. And I had patients that had gunshot wounds and knife lacerations and fractures and breast cancer as well. And that's where I first got my first breast cancer patients. And I thought, I didn't really know very much about it. This was in the early 1990s. And I read stuff on it because there's a lot of things that you have to consider when you have breast cancer patients. And I started working with them, and I was like, wow, this is really interesting and really holistic. I liked how you really had to know about the physical ramifications of breast cancer treatment, and then you also had to consider the cognitive, and then you also had to consider the psychosocial. And what I did at that time was I ended up starting an aerobics class on the outside because I saw that there was a need. And at that time, women didn't even admit that they had breast cancer. Oh. So I remember one woman in my class, she said to me, "Don't tell my son that I have breast cancer." And thank goodness things have changed. I was at that city hospital for about, I forgot. I became a CHT because I had seen so many things. So I was able to pass on the first try, even though I did study for a year. Then I moved into adult daycare for a little while, got my feet wet in school-based practice, and then stayed in school-based practice for 13 years. And I retired from there, and then I'm teaching at the college level. Now, meanwhile, this whole time, I've taught. I've done guest lectures at Montreal College and other places. So it was always in my mind. I give webinars. So I've kind of dabbled in a lot of things.
Yeah. Got a good exposure to what OT offers, huh?
Yeah.
Wow. So then what are you doing currently? Like, what is your role today?
So currently I teach in an OTA program. I teach an introductory course. I also work with older women, and I do Pilates with them. I give webinars. I teach an introductory course at the community college level. I also supervise field work. I supervise students at fieldwork sites, and those sites, for the most part, are Alzheimer's and dementia daycare programs.
Okay.
So it seems like my circle has come full circle.
Yeah. I mean, even using probably, going all the way back to your recreational therapy days, I can just see like how you can integrate all, it's just like from that to schools to teaching to like you said, full circle.
But what I tell my students is a lot of the things that and use in geriatrics, you can also use in pediatrics, as well as vice versa.
Yeah.
Because you will be a more creative therapist and fun therapist.
Fun, because geriatrics can be really, really fun if you let it / make it.
Yes, I agree. I totally agree with you.
Yeah. Well, let's talk a little bit about the Pilates and OT and breast cancer kind of avenue. So first of all, I guess, how do you get referrals? Do you do it like on the side? Do you do it as a part of a clinic, or how does that look?
I started my own small private practice like years ago. And so I marketed to breast cancer surgeons, and women also found out about me because I used to put brochures like in like mastectomy product stores. So I got patients through that. And I wanted to have my own practice so that I could do what I wanted to do and not have the constraints of like a big practice. And so I had patients post Reconstruction. I had patients post mastectomy, post lumpectomy, that type of thing. And I did that, with documentation, and just insurance has become so hard. And so I kind of, left that aspect of it. But I still work with breast cancer clients, just more in the Pilates realm.
Okay. So what point in like their diagnosis, or, do you typically see them after they had surgery, during like treatment session, like during chemo, or at what point what am I trying to say? Like, what point do you see them typically?
So you would see them typically, like, it would depend on the surgery. Okay. Let's say it was a lumpectomy with a sentinel node biopsy. So that's the least aggressive type of surgery, the least invasive. So that would be someone that has like an early stage of breast cancer. So breast cancer is staged from 1 to 4, with 1 being like a small tumor, and then with very little lymph node involvement. And then as we go up the stages, the tumor either becomes more enlarged, or there's more lymph node involvement, to finally stage 4 is metastatic disease. Okay. And what's changed now is that women are living longer with breast cancer and with metastatic disease. And so if you're in geriatric practice, my guess is you are definitely going to be seeing these women. And you should really know some of the issues that these women face, because let's just say you're seeing them for a wrist fracture. Osteoporosis is one of the side effects of some of the medications that they're on. So this could be very, very common. If they're at lymphedema risk, you're not going to want to apply a hot pack to that arm. So it's really important to go back into their history. If they tell you, I've had breast cancer, you should really ask them, well, what kind of surgery? So specifically if they're at lymphedema risk, what type of treatment? Did you receive chemo? Because some of the chemos are cardiotoxic. Some of the chemos cause peripheral neuropathy. And some of the aromatase inhibitors can lead to osteoporosis and arthralgias. So it could be quite possible that in your OT journey, you will see women that can have some of these challenges.
Yeah. Yeah, definitely. I know, like, from my experience, I've seen kind of every stage, right? Like, they've had it years ago, they're in remission, and even people, like you were saying, that people are living longer with some of those, metastatic, cancer, breast cancer. And it's like, I think those are the ones for me that are a little bit more, I guess, challenging, because I'm always a little leery about, okay, like, what can I or can I not do? And a lot of times, some of those people that you just, call the physician's office and get as much information as you can. And then, like the general things like, blood pressure cuffs or like, lymphedema, risk and all those different things. But I think from a clinician standpoint, sometimes it's one of those things where it's like, I'm not seeing them for that. And it's just kind of like, oh yeah, and I have this. And you're like, okay, now making sure that I have as much information about it. And like what are some other, contraindications, or do you know what I'm trying to say?
Yeah. Like somebody, let's say you get them, they had breast cancer 20 years ago.
Yeah.
So what do you need to know about that? Mm-hmm. I would ask them like what chemotherapy drugs they're on, and I would ask them what medications they're on. If they're taking any medications, most likely they're still not taking medications for their breast cancer unless they have metastatic disease. Mm-hmm. But still, those medications can have long-term side effects like peripheral neuropathy and cardiotoxicity. So, I mean, it's just good to know those things just in the back of your mind. Just, most likely it won't be an issue, but it could be an issue. Let's say if you're working on endurance,
right? Somebody
that has, is referred to you, let's say for a hip fracture, and maybe that, you're working on functional ambulation. So their endurance might not be as good as you would expect due to the aging factor, due to whatever reason they fell. Maybe they fell because of they had osteoporosis and they broke their hip, and they've been kind of sidelined. So fatigue can be a long-term side effect of many of the cancer treatments as well. Mm-hmm. And also chemo brain, that's it's really called chemotherapy-related cognitive dysfunction. So that's another consideration, because how you give your directions, maybe they're not following the directions. It's very difficult for women. And by the way, men can get breast cancer too. Mm-hmm. But it may be difficult for them to multitask and also to kind of, understand, a lot of directions at one time. So you may need to give them, instead of 3 home exercise programs, maybe give them 1 or 2 and see how they respond to that first. Because that can be something that, just even from the aging process as well, our memories aren't as good, but also something to consider if, somebody was on chemotherapy. So it's just, and you can do this, there's assessments that you can use to determine that. the Montreal Cognitive Index that you can use. I'm not sure whether I'm giving it the correct name, but there are some very short surveys. In fact, I've used those surveys with my students at the college to give to the clients with dementia. It's like for slight, mild cognitive impairment.
Yeah. Okay. Just kind of getting an idea of where they are and what's kind of going on. How about like for people that have active cancer?
That gets really complicated.
Oh, it's probably way bigger than this. But how about like just what are some general, I'd say, effects that you see? If someone is, like I said, they come in because they have a wrist fracture, but they actually are in, treatment, or they have, active breast cancer. Is there anything kind of that stands out?
Active breast cancer would mean that they are probably a metastatic disease.
Okay.
So let's give a case scenario of someone that's undergoing chemo.
Perfect.
Okay. So they come to you and they could be referred to you for peripheral neuropathy. So let's say they're undergoing chemo. One of the chemo drugs are the taxanes, and one of the side effects is peripheral neuropathy. So chemo is given in combination. So it would be like Cytoxan, adriamycin, and Taxol, and it's given every 3 weeks. So one of the things you have to look out for is their blood levels, because what chemo does, it destroys the cancer cells as well as destroying good cells. So that's why some of the side effects are hair loss of chemo. Other side effects are like losing your nails. Fatigue is the biggest side effect of chemo, and that can last for many years. I had mentioned the cognitive-related cognitive dysfunction, chemo-related cognitive dysfunction, but also the immune system's affected. So their blood has to be tested to see if they're strong enough to receive their next treatment. And there could be like a loss of platelets. The platelets are decreased, or the white blood cells are decreased. Red blood cells are decreased. So that means they might be anemic. So that means they might fatigue easier. If their white blood cell count is down, that may mean that they may be more susceptible to infections. So if you're sick, you wouldn't want to work with them. And then also there's radiation, and that's another treatment. And that could, with radiation, you don't want to use any deep tissue work and no modalities when they're going through radiation. The biggest thing is range of motion, so that they can undergo the radiation, because while they're undergoing radiation, their arm has to be externally rotated and abducted. So that's a big, if you've had any type of surgery, where even though the pectoralis major is not removed, you're going to have scar tissue there. Range of motion is going to be definitely affected. So, you're going to have to really consider that. So it's a whole load of things. You're thinking about the surgery, because you could get them right after surgery, or you could get them after they have surgery and radiation, or you could get them after they've had surgery, radiation, and chemo, and like all those things could be changed around. They could have received chemo first and then surgery. So there's a lot of things. There's a lot of things to consider, but I don't want people to get scared. It's like learning about any other population. The precautions that we have to undertake, and it makes sense. It definitely makes sense. And another consideration is if they've had breast reconstruction, because breast reconstruction can be done at the same time as surgery, or it can be done at a later date. So if it's done at the same time as surgery, then there's other considerations as well. So pain may be in consideration, loss of range of motion, functional ability. I had one woman that had a DIAP flap, and a DIAP flap reconstruction is when you take the skin and the fat from the abdominal area, so they don't take out the rectus abdominis. That's done with a tram flap reconstruction. They bring it over to the breast area. They reconnect the blood vessels up there. So it's like a regular flap. So they have to have like flap precautions as well. And you have to really, kind of baby that area. And then also, weeks later, they're going to have difficulty with transfers. So getting back to this nurse, the nurse that I had, she had this DIAP flap, and it was very hard for her to move from standing to supine. So all our traditional, OT techniques.
Yeah.
I worked with her in side lying. So I did use Pilates as an therapeutic exercise because it was very effective, because she needed that. And with her goal was to be able to ride a bicycle. And because you've had surgery to the breast, this is something else, as well as the abdominal area, there's sensory loss from the chest all the way down to the abdomen. So it was very hard for her to know her like spatial boundaries.
Oh, yeah. Yeah, that makes complete sense.
So that's something else. But to make a long story short, she she was able to learn how to bike ride, but she was a maternity nurse. So she couldn't really go back to that, because imagine, you can't really feel the baby. You're doing a lot of lifting. So she never went back to that. And then she also developed, oh my God, after all that, too, carpal tunnel syndrome.
Oh gosh, that's awful. That's a tough going.
Yeah, it is. It is.
Gosh.
It definitely is.
How do you, let's talk about how you integrate, or how you, complete like Pilates into your occupational therapy treatments with these, with this population.
Pilates has principles that they follow, and those principles are breathing, concentration, control. And by control, we're talking about everything initiating from the abdominals, it's also movement on both sides. There's a lot of integration. And I actually use Pilates with hand therapy patients, because what I would do was I kind of use like the mirror approach, but just a little differently. Like I would have them, let's say they had a wrist fracture. So the same thing can apply to the arm, but I would have them, first I'd always work on breathing. I always do that with everyone, because people don't breathe.
They don't.
Their accessory muscles, they don't use diaphragmatic breathing, and I want to calm them down so they can take in my instructions.
Yes, calm down. No, but yeah, no. It's like you have to start at the basics before we can jump into something more advanced. I really think that. I think that sometimes, yeah, and I think that sometimes like we don't necessarily do that. Like we jump right into looking at their deficits or even just their ADL performance, and it's like, okay, well, let's back that up and just start with, honestly, like you said, breathing or anxiety, or the whole thing is a stressful situation. Like, let's start at the basics. So you start with breathing.
Yes. And I also, I work with the unaffected hand, because a lot of times when you have an injury, you lose that proprioceptive awareness. So Pilates does a lot of, because things come from the center, and it's all about stability. So and posture. So, my whole thing when I was an OT throughout my years was good posture. If you're not starting with good posture, then they're not doing the exercise correctly. And they're not going to get a good result. So I'm like a stickler for posture. So breathing, posture, showing them, getting that proprioceptive awareness of how the normal extremity works, and then going to the affected extremity. So I try to incorporate those Pilates principles into what I'm doing. And I mean, you could do that in supine, you could do that seated, but I go back to the basics. Like I start with protraction, retraction, and incorporate the breathing, elevation, suppression, because what I've learned in my years as an OT and CHT is that you need to have scapular stability. So it's not so much about the humerus as it's about the scapula and getting control of the scapula. And it's really amazing how many people do not know how to use their scapulas. So if you teach them properly, then they learn how to stabilize their scapulas and then get that range of motion. So yeah, you got to back up. I totally agree with you about backing up.
Yeah, backing up. Start at the beginning. Okay. So like if you say you have a referral for someone that comes in, has breast cancer, and you're going to be doing, like you said, you're working primarily with doing Pilates intervention. How do you write goals, or how do you document that? Or do you basically, I don't know, I guess I'm trying to figure out, you probably as a therapeutic activity, or is it more of a
therapeutic activity? It's therapeutic exercises, because I'm not only doing that, I'm also doing the OT stuff with it as well.
Yeah. I guess I was just just kind of figuring out how do you put it all together?
Kinetic activities. Also, there's cognitive. There's cognitive rehab as well. So you can document that too. That's what you're doing. If that's what you see that they need to work on. I mean, you have to prioritize, see what their needs are, just like any other people.
Absolutely, yeah.
So because they'll come to you. I can't remember. I've gained weight. I can't move my arm. My arm doesn't feel as strong. And then I use the dash a lot because that's really functional and tells you the activities that they want to be able to do.
Yep. Yeah, I can totally see how using the dash would. I mean, it's just quick in the upper extremity, just really focusing on what their needs are, and that's kind of obviously what our goal is. So, is there any kind of basic, Pilates type foundational, like you said, you're talking about working on the scapula. Can you give an example of like how you would do that? Like how that would look like?
Okay, so what I would do is I would first work on the breathing. So Pilates breathing is different than yoga breathing. With Pilates breathing, the rib cage moves. So this is really important because you want the rib cage moving with somebody that's had surgery on the breast, because the breast extends from the scapula to I think ribs 5 and 6. I'm not sure whether I have that exact. From the sternum to the mid-axillary line. So, you're dealing with rib cage movement. So Pilates breathing, you inhale through the nose and you exhale through the mouth like a straw. But the rib cage should move and the neck and the upper trap should not. And when I see that tells me that they're not using the diaphragm to move. That tells me that they're going to end up with neck problems, which is very common with women that have had breast cancer, as well as people that have, shoulder issues, because they're using their scalenes. They're using the sternocleidomastoid instead of using the rib cage area. So,
as you're describing this, I'm sitting here trying to say, like, do I do that? Like, I'm just like,
you
breathing
probably
in.
do. Yeah. We all do. It's learning how to get control over it.
Yeah, I can definitely see that.
You know what's really good though? What I love about Pilates and what I had to do and what all my clients do, you close your eyes so you can feel it, so you can get that proprioception. It gets you more into yourself, which is what they need to do. Needs to get them internally activated instead of externally activated.
Mm. Yeah. Well, and just like paying attention and being able to listen and feel your body, like that is a very hard thing for some patients.
Yes, it is.
And
everybody takes to it because they don't want to do
absolutely not. Absolutely not. And like, I even feel like it's something I it's an evolution in my own life, but like, it's like trying to figure it out, like, and we're trained in like, being aware and body awareness and, body and space and perceptions, all these things. So when you're trying to explain it, and it's like, some people just look at you and some people just do not get it. And so like, I think, like you said, closing your eyes and really paying attention to what's going on is a good little trick of the trade.
Yeah. And you know what? Don't feel bad, Mandy, because I've given like live seminars with, her name is Anne-Marie Tureau, and she's an OT who had breast cancer. And her and I worked together when we wrote our book, Pilates for Breast Cancer Survivors, together. Mm-hmm. And it used to be so interesting. Everybody was using their traps at the beginning of the week. Saturday morning, everybody had a hard time isolating. By the end, people were able to tune into themselves, and you could see such a difference in the control that they had over the scapula, over their whole bodies. Yeah. So, it goes back to that proximal control for distal mobility. Mm-hmm. It goes in really well with that.
Yeah. I can definitely see how.
Do you have time? Do you want to try an exercise?
Yeah, let's do it.
Okay. So I find elevation and depression a little bit easier for people to understand. So that's, so I would teach the breathing. So I would teach inhale through the nose, exhale through the mouth, inhale through the nose, exhale through the mouth. And then I teach them, to hold their rib cage, to feel their rib cage, to see if their rib cage is expanding as they inhale. And then moving together as they exhale. So it's a 3-dimensional type of breathing. And if I see they're having trouble with that, I don't go crazy. Mm-hmm. I just say, as long as you're breathing, it's fine. Mm-hmm. So then I go on to elevation and depression. So you're going to make sure that your neck is long, your chest is open, your arms are at your sides, reaching towards the floor. I'm just going to teach the movement first. So we're going to raise our shoulders up to our ears and then bring them down. Fingers reaching for the floor. Shoulders up to your ears and bring it down. Now we're going to combine with the breathing. So we're going to inhale, shoulders up to the ears, and then exhaling as we bring them down smoothly and softly. And inhale and exhale. You should feel your scapulas gliding down your back. 2 more times. Inhale, and now exhale. Last time. Inhale and exhale. So then people gain awareness of what they're doing with their upper traps. Because then when I say to them, you're using your upper traps, then they can understand, oh yeah, right, I'm doing what I was doing before. So this way they're learning how to isolate. And then I go into protraction and retraction, because most people do not know how to use their mid traps and rhomboids. Mm-hmm. And what they do is they bend their elbows. They think if I bend my elbows,
oh yeah,
I'm going to get there. But
that's funny.
No, it has to initiate. So I use, when I go through the Pilates training, they always say to me that I do too much touching. And I always explain, well, I'm an OT. I can't touch. And so what I do with the retraction is I have them protract, and protraction is easy. They understand that. But the retraction, they don't understand. So I have to give them some tactile feedback so they understand, I want you to use these muscles. And for most people, those muscles are like they don't know where the muscles are. They didn't know they had those muscles. And once they feel it, it's like, oh, yeah, now I know what you're talking about. And then they see how their posture improves. And that's like a good motivator, because a lot of the motivation is improving posture. People want to look better.
Well, especially I can see like if post surgery in, you know, like breast removal or something like that, in scar tissue, and you're tight pecs and forward, you know, rounded shoulders, and I can just see how that opening that up would.
Exactly. You know, they get the broken wing syndrome, and then, I mean, after I do that, then I do the, you know, the shoulder rolls. I get into that, so we're, you know, really relaxing, and you know, that, you know, I that's, you know, like those two exercises are like enough, like the first time.
Just getting it going, trying to be body aware and kind of get that moving so that you could progress to X, Y, and Z, right?
Yeah, exactly. Because if you're looking for range of motion, when I got interested in Pilates, it turned my whole idea about rehab around. So before I was always range. Then I got into scapular stability. And actually it's both, but I believe you need to have that stability and awareness first. And then you go into range of motion. Because what most people do is they compensate with trunk extension.
Yeah, exactly. I can totally see that.
So this teaches them, because they think more. I got to do more. I got to show that I made improvements. But they'll tell you functionally, oh, I was able to do this. I was able to do that, you know, better, because they've learned how to activate those different muscles. And the lats are really important too, as well. Like using the lats to stabilize as well. So I always teach, like, one of the things in Pilates is less is more. So go for the stability first rather than that range, and have that stability. So I like that. Less is more. I think it kind of reassures people, like, because we all get into that more, harder. And it's like, you know, let's calm down. Let's, you know, first understand your body a little bit more.
Yeah, then you feel like it would just be more effective in the long run. Yeah. And also, like, you know, if you're giving people home exercise programs, like some people, I mean, everybody has their own style. I totally get it. But you know, some people give these home exercise programs that are just really, really long. And like, I feel like if you want someone to really be, you know, compliant, or, you know, get it, you know, sometimes it's just overwhelming. Like, back it up, give couple, like you said, less sometimes is more. Be more, you know, give them more focused exercise, and we're really working on this. And once we achieve that, we can go to the next step, instead of trying to give them the whole world from the beginning. You know, like, figure out the foundation and then go from there.
Right, exactly.
So what kind of, I mean, you said you have a Pilates certification. I don't know anything about Pilates certification. So is it like a general, or is there different types, or?
Well, now they have like a whole full certification, which I couldn't even consider at my age, where you take a test, and that's where you're competent in all the equipment. There's a lot of different equipment that you could use. There's the reformer, there's the chair. I mean, these are all things that are very supportive of people, and so that they can have, their support, you know, their bodies are supported. And the most comfortable position, of course, is in supine. So, you know, that's another consideration. Like, when you're working in supine, you also can get more proprioception through that. But, regarding your question, there's a lot of different equipment. I use the mat, and I use a reformer. And the reformer is really great because you could do like high, you could do a lot of functional positions. You could do like high kneeling, you could do prone. So let's say you have somebody that has osteoporosis. I can work. I have like one of the things that comes with the reformer is like what can't I remember? It's a box.
Okay.
It's a box that you put on the reformer. So the person, for someone that has difficulty getting on the reformer, they can sit there and they can do the exercises. And there's a lot of exercises that can work the back as well as the arms at the same time. And the resistance can be graded. Now, if somebody's having trouble with the resistance, because it still might be hard for them, then, of course, I would start with the stability and range of motion, and then maybe use weights as, traditional weights to get them so they feel more confident. Because what happens is you have to have everything together when you're challenged by a machine that moves as well as you do. You have to have good stability, in the scapulas as well. Your neck has to be, your posture. You have to have, good core control to be able to do that. So for some people, that may be asking a lot of them. So that's why, like, kind of combining the weights with that is like a modification that I would use.
How about, can you explain, I mean, I'm familiar with the reformer, but maybe if someone is not, like, kind of just describe what it is.
The reformer is a machine that Joseph Pilates devised that has a foot bar, and it has a headrest and shoulder blocks, and there's resistance on it. And that resistance can be a help or hindrance depending on, what exercise you're doing. And there's also straps that you use to put in your hands as well as your legs. So you can, let's say you want to do a arm exercise. So the person would lay down on the reformer. Their feet are usually on the footrest, and you can modify that footrest. You could bring it up, you could bring it down, wherever they're at. Let's say they had a hip fracture, and so their hip range of motion isn't all that good. Then you would bring it up, and there's spring resistance. So I can change the springs and make it easier for them, or harder if they need it harder. But it's like an active assistant. It assists you while you're doing a lot of exercises. So that's why I think it's so useful. So it when you put your hands in the straps, the machine moves and kind of helps you along as you're going. But because let's say you're in supine, you've got the shoulder blocks there. So you're kind of forced to have that shoulder stability while you're there. So that's why supine is a really good place to start for a lot of people.
Yeah. Yeah. Thanks for explaining that. Cause I think it's kind of one of those things, like, I think when you think of
visualize.
It's hard to visualize, but just kind of get an idea of kind of what it is. And I think when people think of Pilates, that's kind of what I think of. Like, you know what I mean? Since I don't use it, but like I think of the reformer. So you had mentioned that you had co-written or co-authored a book. Tell me, how did that kind of come to be, or what is the book about?
Well, I just want to backtrack a little.
Sorry.
Anne-Marie. I met Anne-Marie at a conference in Boston, and so we worked together, and we did workshops together, and then we wanted to write a book. So we actually tried to self-publish a book first that was on Amazon, and then we tried to sell it to, get it to publishing companies, and that was a struggle. But finally, a company did publish it. And, we did it from an OT perspective. So we have like goals for each exercise and why it's important. And we have a seated Pilates program. We have a mat Pilates program and a standing Pilates program. So depending on where they are in a person's journey, you could do all of those. You could progress through them, because getting down on the floor can be hard for people. So doing chair exercises, as we all know, can be, part of that first step. And then you could work on posture in the chair. You definitely can. And sometimes it's really amazing. When I would do these exercises that we have in the book, I was like, oh my God, this is harder than I thought it was going to be.
Yeah.
It really can be. And so like each exercise has like a goal, like this will help you be able to put on your scarf and your hat more easily. This will help you roll over in bed. So we do have a very OT type of focus. And it's also published in Spanish too, as well.
Oh, wow. Gosh, I love that. Because I mean, it's called Pilates for Breast Cancer Survivors, a guide to recovery, healing, and wellness.
Pilates for breast cancer survivors, a guide to recovery, healing, and wellness. So we have like wellness stuff in the back, like hints for chemo brain. I shouldn't call it chemo brain. That's not the professional term. The professional term is
okay.
chemotherapy-related cognitive dysfunction.
There we go. Yes.
So we have that for fatigue. We have like a whole back section, and then resources and all that. You know, when you write a book too, it's like you do the research on it. So there was research. Yeah. But by the time it gets published, it's like there's new research.
I know. It always takes longer than you think. So like you said, it's the research evolves. At least there's research that's evolving in that area. Like I know it's kind of like a limited, for OT and Pilates, but,
There's actually like about 6 studies. And then actually, if you go onto the AOTA website, they actually have, I believe, critically appraised topics. And one of them is cancer. Mm-hmm. And there's no OT articles, but they have things about exercise. They have things about chemotherapy-related cognitive dysfunction. So there is evidence-based information that you could use, even though it's not specific to OT interventions.
Yeah, absolutely applicable. I'll link some of those resources from AOTA and just some articles that you provided, Naomi, for the readers, just to have some more information about breast cancer and OT, and then using Pilates and I'll link your book in there and just a lot of different resources if people are interested in kind of learning a little bit more. Because I think it's an emerging practice area, and it's such a great way to integrate some of those other techniques into OT practice, and especially if there's research to support it, and that it's just like using the evidence and finding what works for your patients and what they enjoy. Like I know I can actually think of a couple patients that I know would really enjoy using some of those techniques, Pilates techniques. Mm-hmm. And, also, just being as client-centered as you can. So, I really appreciate that. So anyway, if everybody would like to check out, Naomi's book and all those resources, I'll have those in the show notes. But thank you, Naomi, so much for talking today about, occupational therapy and Pilates and breast cancer and what our role is in that. And even I love the exercises, just kind of really making sure that we're starting at the basics. I'm going to practice those myself. I need to get good. I need to get good at those if I'm going to try teaching some of those. So I think I'm going to check that out a little bit more. Well, that's the whole
thing. You have to learn. I always find, and this is what has pushed me through everything that I do with OT, and you're probably going to laugh. Like when I would do things with kids, I would always say, if I can't do it, how do I expect a kid to do it?
Yeah, I know.
And then I would sort of downgrade it, but I always would practice it myself because I want to be I'm a very kinesthetic learner, so I want to be able to feel it so I can teach it the best that I possibly could teach it.
Yeah. Make sure you're cueing appropriately and knowing. Yeah. No, I'm the exact same way. I'm like, I got to understand. I need to make sure I understand it and feel it and know it. Because otherwise, like, how can you really teach it? I shouldn't say how can you, because sometimes, I've never had a stroke and I can still teach techniques, but like just the basics, I think it's really important to try it and give it a go.
Yeah, and all these things, by the way, even though our book says Pilates for breast cancer survivors, you could use this book with Parkinson's disease. You could use this book with MS. You could use the exercises with a lot of different special populations. In fact, somebody had said that. I mean, that was our target population. You know, we wanted to get this information out there. That was the population that Anne-Marie and I were, you know, focusing on. But, you know, certainly other populations could definitely benefit from our seated exercise program.
Yeah, I could see that. And especially since it's so OT based and you can just kind of, and it sounds like a progressive program. So that sounds really neat. Well, thank you, Naomi, so much for joining me today.
Thank you.
All right, everyone. Until next time.
Hi, guys. Don't forget to check out the live courses from my sponsor, Great Seminars and Books. I love the variety of courses they offer, specifically because they are relevant to the populations that we are working with every day, older adults. And their topics include things such as home health, a specialty course of its own, and clinical implications of pharmacology for the therapist working with the older adult. So all these topics are relevant, evidence-based, and very practical. These are treatments that you can learn in the course and take back and use right away. So head on over to seniorrehabproject.com/great and use my promo code SRP25 so you can get $25 off your next live course.
This podcast is brought to you in partnership with the Senior Rehab Project at seniorrehabproject.com.